So Dr. Beh, welcome. We really appreciate you giving your time to talk to us today.
Thank you for having me.
Wonderful. Okay, so before we get into the first question, for those people that are already logging on to the Facebook Live, just say hi to us. Let us know where you are calling from, what state you're in, what country you're in, whether or not you have vestibular migraine, if you have vestibular symptoms, and let's get some comments and some chats going. So the first question is obviously the basic one. Dr. Beh, can you explain to us a little bit about what vestibular migraine is?
Absolutely. So vestibular migraine, the best way to understand vestibular migraine is to basically you define it as migraine that manifests predominantly with dizziness and vertigo. Now, as we all know, migraine is more than a headache, and migraine can manifest in many different ways. So vestibular migraine, in essence, is a type of migraine that affects the parts of the brain that deal with your balance, that deal with dizziness and vertigo, and therefore it manifests predominantly with dizziness and vertigo.
That's awesome. So can you explain some of the most common symptoms of vestibular migraine? Obviously, we know there's dizziness, there's vertigo, but we're already hearing from people there's a lot of other common symptoms.
Absolutely. So even in dizziness and vertigo, there's many different permutations of that. So just, for the uninitiated, let's define each one. So dizziness is basically a sense of disorientation without the sensation of motion. So it can mean you feel lightheaded, you feel kind of off, discombobulated, disoriented, feeling as if, just things are not right, as if you're wearing the wrong pair of glasses. Vertigo is more of a sensation of motion when there's no motion that's occurring. The common one that people always talk about is spinning, right? So either you feel that you are spinning or your environment is spinning around you. But there are many other forms of motion as well. Some people feel as if they're swimming. Some people feel as if things are shimmering, tumbling, rolling, flying, many different bobbing, rocking, swaying, a number of different types of motion. So, in essence, there can be many different types of vertigo, many different types of dizziness that a person with vestibular migraine experiences. Now, when you talk about the diagnostic criteria for vestibular migraine, right, you have to have the dizziness and or the vertigo. It has to be accompanied by migraine features, right? The migraine features that are included in the diagnostic criteria, it would be light and sound sensitivity, the typical headache for migraine. So either, one side of the head throbbing, get worse with physical activity, and the visual aura. So those are the ones that are in the criteria. But a lot of people with vestibular migraine also experience a ton of other symptoms which are not included in the diagnostic criteria. With common one being, sensitivity to odors, nausea, and vomiting. Now, nausea and vomiting were not included in the diagnostic criteria for vestibular migraine, unlike for migraine, because anything that gives you vertigo, anything that makes you dizzy can make you nauseous and make you throw up, unfortunately. Right.
No.
You also can have a ton of other things. I know later on we'll be talking about some of the visual symptoms, but all kinds of visual symptoms may occur in people who have vestibular migraine, so visual snow, blurry vision, even palinopsia, weird types of Alice in Wonderland type of visual, distortions, things that feel larger, smaller than they are, closer, further away. Ear symptoms are not included in the diagnostic criteria, but we have to talk about them because they are extremely common. So ear pressure, ear pain, tinnitus is the most common one, or ringing in the ears, can be in one ear or in both ears. Typically, it is both ears in people who have vestibular migraine. You can also experience different autonomic type of features. So some people experience, break out in a sweat when they have, an attack of vestibular migraine. Some get really pale. Some even report that their eyes turn red, get a bit droopy. A bit of a runny nose can occur as well. Weird types of sensory changes also may happen. Some people have this tingling, numbness. Skin becomes very sensitive to the touch. The scalp becomes very sensitive to touch. Essentially, a lot of the features that you can experience in migraine also occur in vestibular migraine.
Right, and that's so fascinating. And I think one of my questions is going to be immediately before we dig in deeper is obviously you're mentioning a ton of different symptoms. So just because somebody gets dizziness during a migraine attack, does that necessarily mean that they have vestibular migraine, or is that just one of the symptoms of migraine?
So not necessarily. So, but if you if you can consistently get dizzy or have vertigo during a migraine attack, you can fall under the diagnosis of vestibular migraine. Yeah, but if you just feel like a little bit off, just not right, that may not completely fit under the picture of vestibular migraine.
Like everything else with migraine, it's complicated. It's not necessarily black and white.
Absolutely.
part of the fun of this disease, unfortunately. So one of the questions we have here is, can you have vestibular migraine without the classic head pain that you normally see with migraine?
Absolutely. So headache is not an essential part of the diagnostic criteria. And it's important to emphasize that because a lot of physicians and patients both make that mistake. So on the patient side, we tell them that, you have vestibular migraine, and the first response is, I don't have a headache, right? How can I have migraine? And on the physician side, they tell patients who will, read up about vestibular migraine and say, do I have vestibular migraine? And they're told, no, you don't have a headache. You cannot have vestibular migraine. So it's important to remember the diagnostic criteria. Headache is only one of the features that is used to diagnose vestibular migraine. If you look at the studies in vestibular migraine, the range of, consistent headaches with vestibular migraine attacks range anywhere from 25% all the way up to 80-something%. So it's a huge range, and it depends on the studies that you look at. A lot of our patients also tend to have, much milder headaches compared to, headaches that they had before. So, most of our patients, in fact, report that the vertigo and the dizziness are far more disabling compared to the headache that they have during a vestibular migraine attack.
Oh, that's really interesting. And I would imagine that it makes it more challenging to get appropriately diagnosed, especially if you're seeing a doctor who's not familiar with the diagnostic criteria.
Absolutely.
Yeah. Okay, so we have a question here about, is it normal to have unusual sensations such as intermittent numb feelings, ataxia in your legs, fatigue, restless legs, twitching, etc., during a vestibular migraine attack?
So it can happen. It's not specific to vestibular migraine, right? But it can happen when you're having a migraine attack. So for sure, this weird, numbness, tingling, unusual types of sensory phenomenon can occur. I mean, we have some patients who even describe weird stuff in their ears, and they see little bubbling sensations in their ears, little vibrating things occurring in their ears. Many different things like that can happen. Now, they're not specific to the condition, but, it's not unusual for them to occur.
Okay, that's interesting. So here's one of the I guess one of the more common symptoms that you see, and I'm not sure if I'm pronouncing this right, but nystagmus, is that correct?
Nystagmus, tomato.
Not too bad, right? Okay, so which is basically, I think, uncontrollable eye movement. Can you talk about the mechanism behind that and the different ways that this might present itself?
Absolutely. So nystagmus is an involuntary rhythmic oscillatory movements of the eyes, right? Usually it arises from a problem in the vestibular system, and basically the mechanism that is designed to keep the eyes steady in the head. So depending on what sort of changes you have in your vestibular system will dictate the type of nystagmus that you have. So essentially, nystagmus is because there is a change in your vestibular symmetry. What happens is the eyes will deviate to one side or another, right? And then another part of the brain tries to make a corrective movement with a quick jerky movements of the eye. So the eyes drift, and then the other part of the brain says, hey, you're doing, what the hell are you doing? Get back. And so it keeps going. There's this little tug of war that goes back and forth. Part of the brain says, no, you're moving, and goes there. And then the other part of the brain says, no, get back to the middle. And so there's this jerky movement. So there's a slow drift and a jerk, slow drift and a jerk, right? Nystagmus can happen with vestibular migraine for sure. More commonly, it happens during the vestibular migraine attack itself, right? When there is a big change in your vestibular system. Now, not everyone gets the nystagmus. I've caught a few patients during vestibular migraine attacks. Not everyone has nystagmus. Some people do. And the type of nystagmus varies. Some nystagmus jerks to the right, some to the left, some goes up, some goes down, some goes round and round. So it depends on each person. Like you said earlier, no black and white, right? Many, many different shades of gray. We are all unique, like snowflakes. And so, everything is different. It is not uncommon sometimes to also have nystagmus between the attacks. So if you examine a person with vestibular migraine when they are not having an attack, they also may have nystagmus, but typically they won't notice that nystagmus. That nystagmus is brought out when we do certain tests where we put this pair of infrared goggles on, take away vision, and so we can see any subtle changes in your vestibular system. Now, to make things a little bit complicated, even people with migraine and no vestibular migraine can have nystagmus if you examine them in the right conditions.
Interesting. Okay, just to add to the complexity of it, which makes it interesting. Okay, we had a couple of questions about the tinnitus that you mentioned, so I'm going to backtrack a little bit. These are some live questions that are coming in right now. The first one is asking if the tinnitus can be different in both ears, like, one more than the other, or ringing in one, roaring, vibrating in the other. And the other question is asking about pulsatile tinnitus.
So the tone of the tinnitus can be different. It can typically it's more symmetrical. Most people find that they hear just one tone because the tone is actually not coming from the ears, it's coming from the brain itself, right? So most people hear a single one in both ears, and that tone can change though. Some people it's constant, some people it tends to vary in the tone. Most people it's about the same tone, but it can vary in the loudness, right? So the volume can change. It can go from to pretty low volume when you're not having a migraine attack, and then when you have a migraine attack, the volume gets cranked way up, and then it comes down again after the attack is over. Tinnitus is very, very common, and so but if you have tinnitus predominantly in one ear, and it is like a roaring type of tinnitus, really loud, like ocean type of roar, a motor type of roar. In those cases, I always want to make sure that the person does not have Meniere's disease. So Meniere's disease is a problem of the inner ear, where the part of the ear swells up with fluid, and then after it reaches a certain level, it kind of pops. There's a leak of the fluid, and then it calms down again. So in Meniere's disease, what happens is, you have the buildup of ear pressure, the roaring of the tinnitus, and then, when the tear happens, the fluid leaks out, then you get the violent attack of vertigo. It's a very, 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 very complicated relationship with migraine. Incredibly complicated. So half of people with Meniere's disease have migraine, right? And Meniere's disease attacks can trigger migraine attacks too. Anything that gives you vertigo can trigger migraine attack. And so what makes it complicated is, if you have vestibular migraine and Meniere's disease, it can be a little tough to differentiate, is this a migraine attack? Is this a Meniere's disease attack? There are things that we can do to determine which is causing what. But, when the two tend to go together, it can be a bit complicated.
No, that makes total sense. Actually, we have a question specifically about that. It's asking about the overlapping of the symptoms for Meniere's disease, but also binocular vision dysfunction, or BVD, and ocular myasthenia gravis. And so how do you know that your diagnosis is correct?
Let's talk about pulsatile tinnitus first, so that way I don't forget to cover that.
Absolutely, no worries.
So the pulsatile tinnitus is, when the tinnitus varies with your pulse rate. I think it can happen in people with migraine. It can happen even if you don't have migraine. The most important thing I would say if you experience pulsatile tinnitus is you need to get a angiogram, right? So it can be a magnetic resonance or MR angiogram or a CT angiogram. To determine if there's any unusual blood vessel malformations in the brain, any aneurysm. Extremely rare, but important to make sure that it's not there before we blame it all on migraine. Now to the next question. You're throwing it all at me, huh? So let's talk about them one by one, because it's lots of different ones there. So like binocular vision dysfunction, it's commonly diagnosed in people who have vestibular migraine and migraine. Now, the trouble is a lot of people with vestibular migraine and with migraine, have trouble with vision, all kinds of issues with vision. The predominant trouble that a lot of people with vestibular migraine experience is they feel dizzy with, a lot of visual stimulation. So, if for looking at things that are moving too quickly, if you're looking at, ugly rugs, if you're looking, down the hallway in the hotel, looking at, blinds, or looking at strap P patterns, going to the mall, Target, Costco, these types of places, right? They tend to cause a lot of dizziness, these types of visually induced dizziness. And so, the trouble is then the condition of binocular visual dysfunction also tends to overlap a little bit. And therefore, so it depends on who the person sees. If they see me first, and then their features fit more with vestibular migraine, then, we give them the diagnosis of vestibular migraine. And if they see predominantly like an optometrist or an ophthalmologist who specializes in binocular visual dysfunction, and then the focus is just on the visual symptoms, then they get that diagnosis. I think it's important to look at it as a whole, because, if you just focus only on certain symptoms, we may miss the bigger picture. So I think if you just have some issues with the vision without other features like with vestibular migraine, if you have a history of misalignment of your eyes when you were a child, then I think binocular visual dysfunction is a very, very plausible diagnosis. if you experience like, other symptoms as well, say, you're off balance, you have these attacks of vertigo, other type of migraine features too that come with it, then I think the diagnosis of binocular visual dysfunction may miss the point, because it then just focuses on only a set of symptoms rather than, the whole constellation of symptoms. Good example, a good comparison is, let's take long COVID. Right. So a lot of people with long COVID also experience trouble with dizziness, looking at things, from both, with are too busy, patterns that are too busy, they get dizziness too. Will we diagnose people with long COVID as just having binocular visual dysfunction? Of course not. Because then in this case, you have to see context as well, right? So the context will tell you that this is more if the person had a history of, this COVID, and then the symptoms started after they recovered from COVID and persist, the diagnosis of long COVID is, of course, more appropriate in that case. Yep. Now, ocular myasthenia. Throwing everything at me. So myasthenia gravis is a very interesting condition. So it's basically, in a nutshell, it is a immunological condition, autoimmune condition, where the antibodies are produced against the neuromuscular junction. So that's where the nerve and the muscles communicate. So a very common type of symptom that happens in ocular myasthenia is paralysis of the eye muscles, right? And the paralysis of the eye muscles can vary from, time to time, right? If you're rested, it goes away. And the more you do with your eyes, then it begins to set it. You can get droopy eyelids as well with it, or ptosis. So typically with ocular myasthenia, the main visual symptom what you would get is double vision. Or if it's like very subtle, then you may get a little bit of a blurriness, a ghosting of an image when you have the misalignment of the eyes. Typically, you won't get the other symptoms that you have with vestibular migraine, like looking at things that are too busy, patterns that are too busy will make you dizzy. Photophobia, for example. Those are not you don't see those in ocular myasthenia.
Okay, that makes total sense. So would you say that those would be like these two, myasthenia gravis, Menieres disease, are they the most common chronic conditions that would be a misdiagnosis for vestibular migraine, or are there other chronic conditions that you also may be misdiagnosed with?
So Meniere's disease, not so much, because Meniere's disease, you have, sorry, not Meniere's disease, myasthenia, right? So myasthenia, not so much, because myasthenia, there are lab tests that you can do. There are, the electromyography and nerve conduction studies that can be done to confirm the diagnosis of myasthenia. And then you also have the double vision that, waxes and wanes, that is more characteristic of myasthenia. So that one is not frequently missed as vestibular migraine. Meniere's disease is often missed as vestibular migraine, or, vice versa. It's often, vestibular migraine is often misdiagnosed as Meniere's disease, because the two have so much overlap, especially, the history of migraine. The two can cause vertigo, the two can cause ear symptoms. And so there's a huge amount of overlap between the two. Misdiagnosis is very common as well, or sometimes missing in one and not the other. Now, so some people with, there are a subset of patients who have both conditions, Meniere's disease and vestibular migraine as well. Yep.
Okay, that makes it more complicated. So I just want to let people know that we are going to get the treatment options, so don't worry. That's on our list of questions to get. I see the questions flying in, and Annie, you're doing a great job in sending me all those questions. So, but a couple of more questions before we get to those treatment options. First of all, someone is asking, what is autologic migraine? Is that even a diagnosis, and is it like vestibular migraine? I know we hear a lot of like weird diagnoses in our group that really are not diagnoses.
Right. So I think I've not heard of the term autologic migraine before, to be honest. But drawing from that, I would imagine that it's migraine symptoms that predominantly affect the ear. So like we mentioned earlier, the tinnitus, the ear pressure, ear pain can happen with it. Even changes in the hearing can occur during a migraine attack. So I'm guessing that's what it more applies to. Now, it'll be interesting to see if there are patients who predominantly have ear symptoms during migraine attacks. Now, if you do that, of course, hey, this may give rise to a whole new type of migraine in the future. Right. We learn more and more.
Who knows? Right, absolutely. So, you know what, let's get on to treatments, because I see the questions coming in about them. So why don't you just, if you wouldn't mind, just start with like the basic immediate approaches that you will get for treatments. And then if you miss something else that's on the question, I'm gonna just kind of circle back to that.
Absolutely. So main thing to remember is the treatments for vestibular migraine are very similar to those for migraine. So, you have your rescue medication, it's the rescue treatments rather, and then you have your preventive treatments and you have your lifestyle changes that you need to make, right? So lifestyle changes are pretty much the same. Manage stress, routine, sleep routine is important. Regular eating habits would be important. If you have any triggers, avoid the triggers if you can, right? When it comes to preventive medications, you have the whole arsenal that's available to people with migraine, right? So, it ranges anywhere from the antidepressants, the older antidepressants like the tricyclics, the newer antidepressants. You have the anti-epileptic medications that also work really well. You have the blood pressure medications, which consists of like the beta blockers, and then the what do you call that? The ACE inhibitors, the ACE receptor blockers. You have the what else do we have? We have the calcium, so many of them. We have the, excuse me, the calcium channel blockers as well. You also have the newer medications, like the CGRP blockers that are also available to us. Then you have those that you cannot really categorize into any specific group. You have those like memantine, which are used in some people. You have some like, Singular, which you use in some people as well. So you have basically all the options, Botox, not to forget. We have all the options that are available to people with migraine can be used to treat vestibular migraine. Now, the acute treatments also are very similar. You have, all our good friends, the triptans, don't ever forget about the triptans. I know we have new stuff that's coming out, but hey, the triptans still play an important role in the treatment of migraine. We have, of course, the G-pens, which are the new ones, the ubrogepants. We have ramagepant as well. One probable group that we don't commonly use in people with migraine that we use in vestibular migraine would be the benzodiazepines. So medications like Valium, clonazepam, lorazepam, those tend to work quite well for like vertigo to shut down, the vertigo to shut down the dizziness. Not, of course, not as commonly used in people who have migraine symptoms like migraine headaches and all that. Could they also work in people with migraine? I don't see why not. But those I would say are predominantly used in people who have vestibular migraine. And of course, you have the symptomatic ones. So, the ones that help with nausea, the promethazine, ondansetron, things like that to help with the nausea. And also all the other, non-pharmacological ones, ice pack on the head, dark room, dark glasses. You have the devices as well that could also potentially help for rescue.
Right. So I think we covered pretty much all the medications that we had the questions for. If I missed something out, or Dr. Beh missed something, then please just re-ask that question again and we'll come back to it. In terms of the devices, do all of the medical devices, are they all feasible to be used specifically for vestibular migraine? So we're talking about Gammacore, Nerivio, Cephally, the STMS, which is now called the Savvy, and Relivium, which is the newest one. Are they all used for this?
So in my experience, so the studies that I have done, concern mainly the Cephally and the Gammacore. So both shown to work well for rescue. I have patients who use it for prevention as well. So those two for sure I know, can be used in the people who have vestibular migraine and migraine. Nerivio, I've not used it in our patients so far. So, predominantly we know that it can help with the pain part of the migraine. I don't have the data to support whether it can help with vertigo and dizziness. Now, does that mean you can't try it? Absolutely not. It's safe, super safe. If you want to go ahead and try it, I have no opposition to that whatsoever. Relivion, we haven't used that yet in my patient population that I've seen. I think predominantly because are we available? Is it available for prescription everywhere yet or not yet? That's something I'm
Yes,
not sure.
well, the Relivion is available prescription at the major headache centers, but it's not widely available at all at this point in time.
Unfortunate. Yeah.
Unfortunately, so a lot of people wanting it.
Exactly. That could work. I don't know what they are, they're doing. Yeah, I think you have to go and, beat them a few times to get them to hurry up.
We're working on it. We're like, we want this, and they're promising us that it's going to be rolling out later this year. So hopefully.
Fingers crossed.
Yeah.
I don't see why it shouldn't work. So, if the Cephally works with the trigeminal stimulation, I do anticipate that, we could get some benefit from our Relivion. STMS, unfortunately, also not been tried. I mean, there was the issue with cost, unfortunately, before. Right. It's, unfortunately, not very cheap. Still not very cheap, from what I hear.
Yeah, it's not at this point in time.
Yeah. Worth a try, if you can get your hands on it. The good thing about the devices is, safety-wise, they're pretty good. You know, we don't worry about medication side effects. We don't worry about, like toxicity. If you need to use it a bit more than usual, there is really no safety issues unless, of course, you have implantable devices and all that, which you shouldn't be using those devices in the first place. But I think they're very flexible. They provide a very good, pharmacological option for a lot of our patients. So, I think they're all worth a try. Cost is the biggest issue from what I can see.
Right, absolutely. And some of them are definitely more affordable than others. And obviously, if it relates to your symptoms, then the cost may be worth it. And we are also, I know that they're working on insurance coverage, and for the VA that already covers a lot of them. And some insurance is starting to cover these devices as well, which is really exciting. So hopefully that will continue. Somebody here actually asked about that you have apparently referred in a previous session to French cooking. And I'm not sure what that refers to, but I'm thinking maybe it just means kind of a little bit of this and a little bit of that, but
a little bit of this, a little bit of that. Yeah, absolutely. So a lot of our patients also are pretty sensitive to medications. I'm sure you've experienced that. You hear that quite a bit. So people with migraines tend to have, far more sensitive brains compared to people with migraines. So, smells can be too much, lights can be too much, sounds can be too much, and of course, medications, right? And so what we do a lot of times is if we see that, we have some patients who, cannot tolerate above a certain dose of a particular medication, rather than just, try to keep pushing it higher. Sometimes, if they found that, a low dose of medication A seems to be helpful, but they cannot tolerate a higher dose and there's still room for improvement, we add medication B. If the same thing happens where they get further improvement, but cannot tolerate a higher dose, then we add medication C. So, it's the thing about it is, I always tell our patients, don't think of it as an algorithm, right? We don't follow algorithms. I think that's the wrong approach. You take where, oh, everyone has to start with this and then go to this and then this and then this. I don't think it works that way. I think everyone has to have, their own personalized approach. Depending on what the person's history is, what their preference is, their point in life, other issues that they're dealing with, then I think we need to tailor their medication or their treatment plan for them that way.
Absolutely. I mean, we always say that, migraine is a complex disease. It's a messy disease. There's no one size fits all. For those people who aren't aware, on the Migraine Meanderings website, we have a toolbox that you can go into and you can download that has all of the most common treatments for migraine, but not only like prescription medications, but also the devices, lifestyle options, integrative treatments, supplements. So go and take a look at that. And if you could put down that link in the comments as well, so people have that. And hopefully that will be helpful. And just because something worked for me doesn't mean it's going to work for you, and vice versa. Just because something worked now doesn't necessarily mean it's going to work in 5 years' time for you as well. So sometimes you have to have this toolbox approach or the French cooking approach, which I kind of like that. Maybe we should rename our page, French cooking for migraine. That would be kind of interesting.
Sounds more delicious.
It is more delicious for sure. Let's backtrack a little bit before we get to some of the newer questions. Can you explain a little bit about what persistent postural perceptual dizziness is, or PPPD?
Absolutely. So triple PD, it rolls off the tongue better when you say triple PD, is not to be confused with BPPV. BPPV, or benign paroxysmal positional vertigo, is a completely different condition, but unfortunately the names are sound the same, right? So BPPV, very quickly, is a condition where there's a loose crystal that rolls into a part of the ear that causes you to get vertigo. If you move your head in a specific way, you roll in bed, you get a brief attack of vertigo. That's a different condition altogether. Triple PD is more of a condition where, you feel this constant level of dizziness. You feel just dizzy all the time. And it can be lightheadedness. It can be you discombobulation, feel disoriented. Things just don't seem right. Things don't look right to you. Just feel kind of off. Some people describe it as feeling kind of tipsy, some as feeling drunk, some feeling as if they just got off a ride, or just feeling motion sick all the time. A lot of the patients also, like we mentioned earlier, get really, really, really dizzy if they look at certain visual stimuli, right? So like, talking to people like myself who move around too much, or, who look at, the computer, there's a lot of scrolling, or if you're looking at a TV and then, your spouse is, flipping through Netflix trying to find a program, and all the movement tends to throw you off. Looking at cars moving ahead of you, in front of your car, or besides your car, throws you off. So it's not a specific condition related to any particular cause, right? Many things can cause triple PD. It can be caused by, really high amounts of stress. It can be caused by any medical illness. It can be caused also by anything that gives you vertigo or dizziness.
Okay, interesting. So from what I'm hearing from you, that what you're saying is triple PD doesn't just necessarily last for those 72 hours during an attack, but it can be beyond. So we have a question about that, where someone's asking about dizziness and instability lasting longer than that at a time.
So the 72-hour mark is, I think you're referring to like a vestibular migraine attack. So in the definition for the criteria, it lasts from 5 minutes to 72 hours. That's a vestibular migraine attack. Triple PD is more of a constant type of dizziness, right? You feel that all the time, almost all the time. And in the diagnostic criteria, it has to be 3 months before you get the diagnosis.
Interesting. Okay, that's interesting. So I also just wanted to add that we see that in classic migraine as well, migraine with aura, that there's that 72-hour cutoff, but a lot of people in my group, and I know a lot of people with migraine, we have migraine that lasts longer than that typical 72 hours. And that doesn't mean it's not migraine, right?
Absolutely not. So, I think the 5 minutes to 7, I tell all our patients, so don't get too caught up with our diagnostic criteria. The diagnostic criteria are useful to guide the diagnosis, and they are useful for clinical trials. Of course, if a person experiences migraine attacks that last for 2 weeks, right? Would that mean that they don't have migraine? Absolutely not. Would you include them in a migraine trial? Answer is no, right? Because then in the migraine trial, because you need some level of uniformity, you need to follow certain criteria. But that won't change in, the diagnosis. That won't change treatment, in more of a clinical setting where our goal is to diagnose you with what you have and to help you get better.
Right, absolutely. And we see all the time, I see in discussions with other organizations that most migraine patients do not fit into that neat little box. But for the clinical trials, you do need to fit into a neater box, which is one of the challenges with clinical trials of migraine, because it's such a messy, complex disease. And so a lot of time you find the people who are going to be first to get these new medications are not the people allowed into the trials, which is a frustration, but understandable as well.
Yeah, absolutely. They need some level of uniformity for data.
Right, absolutely. So one writer who commented a couple of days ago said that certain rooms and floor surfaces, different lighting can aggravate their vestibular migraine symptoms. Is that normal?
Absolutely, incredibly normal. So a lot of patients with vestibular migraine tend to be exquisitely sensitive to visual stimuli. So, if it's like certain lighting, it's a combination of things. So, there's the light sensitivity for sure. So if there's a lot of overhead fluorescent lights, very shiny floors, shiny surfaces, that tends to aggravate the symptoms. If it's like very long hallways, then that tends to make people a little bit dizzy. Or if they go into certain stores, like, they go into a Target or Costco, especially they go on a weekend where, there are crowds milling around, people moving around, that throws people way off.
Okay, so that's really interesting. Now let's kind of switch a little bit and let's move to like comorbidities. Is it that we know that we're regular migraine, there's a ton of comorbidities. Is it any different with vestibular migraine? So people are asking specifically about trigeminal neuralgia, multiple sclerosis, thyroid disorders, and other things such as that.
So multiple sclerosis, I'm not aware of any like specific studies to show that it's more common in people with vestibular migraine or vice versa. Now, I do have patients with vestibular migraine and with multiple sclerosis. So I think the thing is, sometimes the trouble that people run into is, if they have multiple sclerosis already, and then they start to develop dizziness and vertigo, automatically, the assumption is, oh, it's your MS, it's not, something else. We are like Occam's razor where, we want one single diagnosis to explain everything.
Right.
And, unfortunately, like you say, life is messy, right? Beautifully messy. And so, you can have more than one condition. That, Hickham's dictum says, a person can have as many different conditions as they damn well like, right? So, you could have many different things going on. The comorbid conditions like with migraine, so thyroid disease, I'm not aware of any like specific relationship to vestibular migraine, but it's important to remember that any thyroid disorder can cause neurological manifestations, right? It could make you dizzy, could give you vertigo, could cause all kinds of things. So, if you see a person for the first time with, vertigo, dizziness and all that, I think part of the workup, is to look at the thyroid function. Same thing like with B12 levels. So B12 levels, low B12 levels can often cause a ton of neurological problems. And so checking that is also very important. We always also look for things like, HIV, syphilis, just to make sure, that they are not present as well, because those also can cause other neurological problems. Now, the big comorbidities that we tend to see people who have vestibular migraine would be, trouble with, their menstrual cycles. So a lot of people who have like endometriosis, polycystic ovarian syndrome, also can have issues with migraine, with vestibular migraine. People who have BPPV, or benign paroxysmal positional vertigo. So that is also an interesting comorbidity in people with migraine and vestibular migraine. So incidence is definitely higher, and people who have migraine and vestibular migraine tend to have a higher rate of recurrence of BPPV attacks compared to people who don't. Why that is, no one completely knows, but it could be related to inflammatory changes in your inner ear. Meniere's disease, and like we mentioned earlier, there is a higher comorbidity in patients with migraine, with vestibular migraine as well. The psychiatric ones, are not to be, excluded. Depression, risk of depression is very, very high as well, right? As with migraine, it's also high with vestibular migraine. I think the big one where we tend to see a much higher rate is in anxiety disorders. So in anxiety disorders are, very, very common in people who have vestibular migraine, and I think much higher compared to people with migraine. And the reason is, anything that gives you vertigo, anything that makes you dizzy will make you anxious, unfortunately. And Dr. Teggi in Italy did this beautiful study where he looked at people who were admitted into the psychiatric units of the hospital. Those with depression really didn't complain too much about dizziness, whereas, those with anxiety had a much higher complaints of dizziness.
Absolutely. Now talking about the diagnosis and the comorbid conditions. So someone is asking if you're reacting well to migraine medications, for example, like the CGRP inhibitors. Is that sometimes a diagnostic criteria in terms of, now that it's more likely to be vestibular migraine than something like Meniere's disease?
Unfortunately not. So the diagnostic criteria does not take into consideration medication response. Now, personally, it does help a little bit. Now, CGRP is an interesting one because, even in Meniere's disease, because there's an inflammatory component to it and there are CGRP receptors in the inner ear, I don't think a response to CGRP would be that diagnostic. Now, if let's just say the person has responded to an anti-epileptic medication, right? Say like topiramate or zonisamide, lamotrigine, one of them, right? And they also have Meniere's disease. That sense, it kind of like, points more towards the migraine side. I've been surprised many times too. There were patients I would have sworn had Meniere's disease, but we say, hey, you know what? Let's try treating you with, a migraine medication, and lo and behold, they get better, right? There are even people who, some of our ENT colleagues who use, nortriptyline to treat people with Meniere's disease because, there's so much overlap with migraine.
Right, absolutely. There's so much overlap. Now, I'm presuming, but maybe I'm wrong, that similar with other types of migraine, people can, their triggers or the things that make it worse can be very similar in terms of allergies, weather changes. People are asking a lot about menstruation and hormones, that type of thing.
Absolutely. Biggest one from our patient population, stress. Stress, that's the biggest trigger. Weather changes also a very big one, not enough sleep or, sleep irregularities, skipping meals can also do it. And of course, hormonal changes. So most people, it's around the menstrual cycle. Some people at ovulation as well as when they have their menses. A lot of them, after pregnancy. So generally during pregnancy, again, following the pattern with migraine, the symptoms tend to behave themselves quite well. But once you deliver and then there's a big drop in your hormones, then that's when the problem tends to start and kick up.
Right.
Yep.
And then I imagine that,
ones.
I was going to say, I imagine that menopause is a similar type of thing, is that if you're hormonally directed, theoretically, it may get better after menopause, but as with other types of migraine, it may not. Is that true?
So menopause is a very fascinating one. So generally, the pattern that we see in our patients is, a lady who had regular migraine headaches early on in life. Headaches come, headaches go. And then they tend to get better as the person approaches menopause and they go, oh, thank God, my headaches are better. They've gone. Yep, beautiful. But then vestibular migraine sets in. And instead of headaches, they start to get vertigo and dizziness. That's the pattern we tend to see a lot in our patients. So again, going back to the whole hormonal thing, it's not as clear cut, right? So it seems that, the hormones, before menopause, the headaches tend to predominate. But after, towards menopause and after menopause, it's when you tend to start to see more vestibular symptoms manifesting at that time and less headache.
That's unfortunate. That's a sad situation. Is there specific treatments that you would use for hormonally triggered vestibular migraine, or is it the same as everything else? It's just kind of, it's a trial and error approach.
It's fairly similar. Some of the differences, like, we see with other, with the treatments we use in vestibular migraine are also very similar to migraine. So, sometimes you use like, naratriptan, triptan around the time of, the menstrual cycle to see if you can calm things down. Some people use, acetazolamide around that time. I've seen even some people use other antidepressants around that time. Supplement-wise, you can do like vitamin E, ginger around that time. I've seen some patients use the benzodiazepines prophylactically around that time. So there are many different things that can be done around, the menstrual cycle or ovulation to try and keep the symptoms under control. If those fail, then, unfortunately, sometimes we have to go with like the hormonal interventions, either like very low estrogen contraception or going with the progesterone-only contraception.
Absolutely. Okay, so that makes sense. Let's switch to non-pharmaceutical treatments, not the devices, but people are asking, how do you heal from this naturally, bearing in mind that there is no cure for vestibular migraine any more than any other type of migraine? What are the more natural treatments? Let's talk about vestibular rehabilitation therapy and physical therapy.
Okay. So vestibular rehabilitation therapy and physical therapy, the goal of those would be to desensitize you, right? So, if you find like, certain hip movements make you dizzy, looking at certain things make you dizzy, then the vestibular therapist will help design exercises to help, you overcome that. So they'll start off at a lower level, and then, eventually as they see that you're doing better, then you start to get better. So people who have like, gait problems, because of the dizziness, the vertigo, then they also will help train you, get you better. The people who have developed like neck problems, muscle problems from, being too dizzy all the time, because the natural response when you're dizzy is, guess what? Stiffen up, right? Stiffen like a board. And, that can cause a lot of neck and shoulder issues. So some of our physical therapists also engage in, neck massage, dry needling, giving you, neck therapy to help loosen the muscles and reduce the pain in the neck. So that is the biggest, the parts that we'll send patients to vestibular therapy and physical therapy for. Other types of, interventions would be, of course, our good friends, the supplements, right? So supplements, are a big part of treatment as well. The big ones that we use in migraine with a ton of clinical, support for that would be, your vitamin B2, magnesium, coenzyme Q10, vitamin D, melatonin. You have feverfew that we can also use as well. So those are the very big ones that we tend to use a lot in our patients who have migraine. They are very, very safe to take, and so, we always encourage our patients to take them, unless, of course, you develop some bad side effects to them, of course, right? Which is extremely rare. But, if you do, then we tell them not to take it. Other supplements also can be useful. There are like smaller ones that, there's some studies that show that they work. For example, if you take like, like which ones are we talking? Like vitamin B12, this vitamin C potentially, ginkgo, things like that could potentially work. It's just that with those, the trials, the clinical studies were smaller and there's not as much evidence as the other supplements that we talked about.
Right, absolutely. Thank you so much for that. I know that we're covering like a huge amount of information in this session. We only have 15 minutes left. Just to let people know, we will also be putting this onto our YouTube channel so you can watch it again and again, and gain as much wisdom as you would like from Dr. Beh. A couple of questions here about neck issues, about whiplash, people who've had cervical fusion, and if why that would aggravate vestibular migraine, and then would you recommend chiropractic adjustments?
So neck issues are extremely common, right, with people with migraine and vestibular migraine. It's not just, having neck fusions and all that. So like we mentioned earlier, a dizziness, every time you're dizzy, you stiffen your neck. And so that can, in the long term, contribute to a lot of neck issues. The cervical nerves, are very closely related to the trigeminal nerve. Right, the two interact together. That's why it's called the trigeminal cervical complex. And so, any problems affecting one system can bleed over into the other system. So people with migraine can experience neck pain. People who have neck injuries and all that, it can aggravate the migraine for sure. So there's this very close link between the two. A lot of times, if you have a neck injury, arthritis in the neck, any neck problems, that often, when it flares up, that can aggravate the trigeminal system and contribute to migraine attacks. Now, there is the entity of cervicogenic dizziness, which, I think that's a different talk altogether. But, in a nutshell, the neck is full of nerves that control, balance, right? They tell your brain what the neck is doing in relation to the head and to the body. So your brain knows, whether what the body is doing, right? So it's not just, what the head is doing. The brain also needs to know what the body is doing to keep you balanced, right? So the neck plays a huge role in that. So neck injuries sometimes can injure those nerves. And, if you injure those nerves, then you also can develop dizziness coming from the neck. Chiropractic treatments, it's a tough one to talk about because there's so many different ones, right? There's so many different things that falls under that umbrella. So, the big ones I would say would be, I'm okay with patients who go for, like the manual adjustment, like the myofascial release, the gradual type of movements. Those I have no problem with that. In fact, I think those can be very useful. Some chiropractors even do vestibular therapy. So, the vestibular therapy that you can get from like a physical therapist or a vestibular therapist, that would be fine. I know, completely okay with that. Where I tend to get a little bit uncomfortable is the ballistic movements, where they do the snapping movements and all that. That I've seen, there have been a few like rare case reports here and there where people who have, certain conditions like Ehlers-Danlos, where the blood vessels are a little bit weaker, then, when you have those types of maneuvers where you snap the neck, that could potentially tear them and give you a stroke. So those I tend to advise our patients be just a little bit careful with that. I've heard of the upper cervical adjustments as well. So some people swear by it. Some people say that it doesn't work. Personally, if it was my neck, I think partly because I've seen a lot of patients who had poor outcomes from it, I would not go for that one personally. But the rest, I think I'm okay with.
Okay, that's good to know. Let's do a complete pivot in our last 10 minutes. Let's talk about some of the research that's going on and also the importance of getting diagnosed correctly. So the first question is, because people are talking a lot about hope. We know with migraine that people tend to lose hope, discouragement, depression, suicidal ideation is very, very common and very common in vestibular migraine. So people are asking, will I ever be able to drive again? Is there hope for me? Will I ever be able to recover? So if you could maybe talk about the latest research for vestibular migraine, whatever you're aware of, and what would help people hold on to hope for this disease.
So hope and the latest research, let's talk about them separately. So hope is very, 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 very important for our patients. It's important, for you not to, think that you will never get better. More than 90% of my patients get better. They go back to normal lives, they drive, they go back to normal family functions and everything. And so, the chances of recovery is extremely good. Very, very good. And that leads into the next part where, the importance of the diagnosis. The importance of the diagnosis is so that you can get on the right treatment plan, right? Of course, then you also know the enemy that you're dealing with, what you're dealing with, and then, of course, you can tackle it better. I think the part that contributes a lot to the depression and the psychiatric burden of the disease is the unpredictability, the uncertainty of what's going on, right? If you don't know what you're dealing with, then, you have this condition that, no one knows what you're dealing with. You don't know what it is. And of course, there's the fear, right? But once you know what you're dealing with, once you see the condition that you're dealing with, then that focuses your energy, to a greater degree. You can just say, all right, this is what it is. Here's how we're going to tackle it. And then working with a physician who can direct you, what we should do, what treatments to institute, what to do about it, that will help you get better in the long term.
Right.
Vast majority of people do get better. That's most people get better. That's beautiful, right? And that's the beauty of, migraine. On one hand, it is a very disabling disease, definitely. On the other hand, it's a very treatable disease. It's not curable, but it is treatable. And a lot of people do get better. I think getting on the right treatment plan is extremely important to help, in that recovery. The latest research into vestibular migraine, I think the ones that stand out to me would be, the latest ones in CGRP, right? So, there are some studies going on in the CGRP inhibitors to see whether they work or not in vestibular migraine. Having the trials would be great, of course, because that lends further support to, using them as treatment for vestibular migraine. But, personal experience, I can tell you, they do work, right? Do they work better than the other ones? No, they're part of the things that can work. They're not by any means magical, but they definitely do work for a lot of our patients, both the injectables and the GPAPs. They do work. Yeah. I think other latest treatment studies, help clarify it a little bit more. So like the big one that came out, not too long ago was, defining vestibular migraine in children, which, also uses the same criteria as the adults, but the good thing is that now at least, we recognize that there's the entity in children. I think that also helps open the way for more clinical trials. And of course, fighting the dreaded and the devilish insurance companies to get the right treatment for people. Yep.
Right. I appreciate you covering that because we did have a couple of questions about children, whether you see this in children, how common is it, and similar questions to that. So,
yep. So in children, so bear in mind, of course, I'm not a pediatric neurologist. Generally, I see patients 13 and above because, by then physiologically, most are, kind of adults already. But generally, from what I'm aware of, the most common cause of vertigo in children is migraine. A lot of our ENT colleagues who, I talk to, they feel that, migraine is actually the biggest cause of vertigo in children. In fact, they actually, the form of vertigo, like called recurrent vertigo of childhood in kids, it's migraine.
Right. So let's talk about children for a moment, because we had someone just ask a question. Please ask about how children are supposed to cope with this and in school. And of course, we know that obviously it easily gets missed in children, but we also know that treatments are often not tested on children. What would be your strategies or your recommended strategies for children?
So unfortunately, when it comes to like the treatment of migraine in children, it lags behind adults, let's be honest, right? It's, I think part of the reason is, we tend to be far more cautious when it comes to children as we should. We don't want to throw medications at children unnecessarily. But on the other hand, that caution also can result in, a very slow development of,
Right.
the science. And then therefore, if we just rely on using, evidence-based medicine, quote unquote, even for vestibular migraine, everything I choose for vestibular migraine is, guess what? Off label. There's nothing on label for vestibular migraine. And so in the same thing too with children, we have to be, I think sometimes a little bit unconventional, a little bit unorthodox. If the treatments are fairly safe, we feel, you feel that the treatments are fairly safe, I think it's fair to start the treatments for those patients. I think it's not appropriate just to say, oh, there's nothing that's been approved for children, therefore we shall do nothing. I don't think it works that way. I think if as long as a treatment is fairly safe and the child has significant symptoms, it's important to bring it under control and to get the child on the right treatment for those things. Coping is a tough one. Right, because on one hand, it's difficult when you see your child, suffering dizzy all the time, can't function, can't play, can't watch TV, can't do anything, right? It's a very difficult situation to be in, can't go to school. I think parents in that situation, you'll have to find the right accommodation. So I've worked with some parents, teenagers, what they do is, they try to get accommodations where the child can work from home, study at home for a period of time, or they have for like certain accommodations at school where they get more time for exams, for example, get to take time off here and there, stuff like that. I think it's very important because we have issues where we are asked to write letters, right? It's very difficult for me to write the exact accommodations for a person or a child, right? Because I don't know their circumstances exactly, like what they can how much they can tolerate, what the school setup is like, how big the school is, what goes on in the school. I have no idea, right? So in that situation, I think I have the parents, take a very more proactive role in it. Write the letter out, write exactly what accommodations you need, and tell me, and then I can get that for you.
Right, absolutely. And there is an organization called Migraine at School, which has some suggested accommodations, which may or may not be helpful for your child. As you mentioned, Doctor, every school situation is different. Every child is different. One of my children had to have alternative schooling options, partly at home, partly in an alternative school because of migraine. So it's a radical thing that some parents have to do, but we do need to protect our children. And the approach of, well, there's nothing approved for children, so we just got to let them suffer is just devastating. So I appreciate you saying that. Also should note again that there are a couple of devices that are approved for adolescents. So that may be an option to look into. Let's pivot in the last 2 minutes, literally our last 2 minutes here. What type of doctor should someone see for vestibular migraine as an adult? And then what type of, because I know you cut off at a certain age, so what type of doctor should someone who is a child, let's say who's like pre-adolescence, what type of doctor should they see?
So for adults, the main ones they will be naturally referred to if they're dizzy or have vertigo would be, ENT they will go to ENT first, naturally. And then some after that, if it's found not to be an ENT related issue, then they get sent to a neurologist. So even neurologist or an ENT would be okay for, managing vestibular migraine. A lot of times, unfortunately, because there's a disagreement between the two, then the ENT says it's not an ear issue, it's a brain issue. And the neurologist goes, no, I don't think it's a brain issue, I think it's an ear issue.
Right.
And so they get caught in the middle, and I mediate in that situation, right, to determine which is which. But there are a lot of good ENT doctors who are, very comfortable treating vestibular migraine. The community, vestibular migraine community are familiar with our ENT colleagues who treat vestibular migraine. And so, going to see an ENT doctor who can treat your vestibular migraine is good. If you see a neurologist, especially like a headache specialist, who's also familiar with vestibular migraine, that will also be great.
Okay,
so for children, yeah. So children usually they go see about the same thing too, right? So you see a pediatric ENT specialist, and you also have the pediatric neurologist. For the pre-adolescents, I think the important thing is, for the thing that also strikes fear in me is that there are so many other things that could cause problems, at that age, right? There are like so many other genetic conditions that I am not aware of that that can affect children. And so I think working closely with like a pediatric neurologist to make sure that the child is not experiencing any of these other conditions would be very important before settling on the diagnosis of vestibular migraine.
Right, absolutely. Thank you so much for that. And as we come to a close, if we could just put on the website for Dr. Beh so that people have the resources for him would be helpful. Thank you so much for being with us today, Dr. Beh. We really appreciate it. Thank you everybody who joined us today. I think by the looks of the questions, we didn't even get through half of them. So I think we're going to do a follow-up session if that is okay. But I hope that everybody here has, thank you. I hope everybody here has found it helpful. If you have any comments or questions that have not been answered, please just ask them again, highlight them, and we will gather those questions together. So just let us know about that. We know that vestibular migraine can be incredibly disabling. We encourage you to proactively partner with your doctor. So if you have not found success with your current doctor, don't be afraid to look outside and look for other resources and another doctor to explore different options and create an action plan to help manage this disease. So we're going to say goodbye to today. Thank you again, Dr. Beh.